Well, welcome everybody to Optometry Education Consultants National Webinar Series, Sunday night edition. It's our great privilege to have Dr. Kelsey Mileski doing our presentation tonight. She obtained her optometry degree from the Pennsylvania College of Optometry at Salus University, followed by a residency training in neuro-ophthalmic disease at Salus. She stayed at Salus as an instructor and taught optometry students in courses including neuro-ophthalmic disease, neuro-anatomy, head and neck anatomy, and clinical skills, as well as seeing patients in primary care in the neuro-ophthalmic disease service. She relocated to the Atlanta area afterwards and joined Emory Eye Center as faculty. She now is in private practice in the Jacksonville area. She is also an assistant professor of optometry at the University of Pikeville, Kentucky College of Optometry, also known as KICO, where she is a course director for neuro-ophthalmic disorders. She is an active member of the American Optometric Association, a fellow of the American Academy of Optometry, and also serves as a program chair for the neuro-ophthalmic disorders in optometry section. And that's where she and I get to work together extensively. We've had her lecture at our meetings live. She's a wealth of knowledge, a great presenter. I'm really looking forward to this meeting, this webinar. So Kelsey, please take it away.
All right, thank you. Appreciate it. Well, welcome, guys. Welcome. Happy daylight savings. Hopefully, everybody got an extra hour so we can do some extra continuing education here. So, today we're going to talk about vascular disorders and vision. I have no financial disclosures, and this will be our course breakdown for tonight. So, we're going to first talk about stroke. We're then going to go through more of the anatomy aspect of blood flow to the brain, and we'll pull in some different clinical correlates and how it might present from a clinical setting. We'll then go through some specific clinical cases to reemphasize those points. We'll then shift gears and talk more so about blood flow to the eye, and then talk about ocular manifestations of specific vascular disorders, and then again, finish out here with a couple clinical cases. So when we talk about stroke, stroke in general happens due to blockage of a blood vessel that's going to the brain. And that blockage can be physically blocking the blood vessel itself or the blood vessel breaking in terms of rupture. It is the fifth leading cause of death and leading cause of disability in the United States. And we have three different types of strokes that can happen. We have our ischemic strokes, which are most common, our hemorrhagic strokes, and then finally our cryptogenic strokes, where really the cause is not known. Now, the most frequent type of stroke we're going to see here, and I'm going to get my laser pointer going, is going to be an ischemic stroke. This is going to be almost up to 90% of strokes. And this can happen from one of two different reasons. So it can happen from either a thrombosis or an embolism. So with thrombosis, we're going to get kind of like a flat fatty plaque that builds up in the blood vessel itself that's going to kind of fully block it. Versus an embolism is going to come from somewhere else. And we see that happen usually somewhere in the carotid arteries or potentially in the heart. And when it's coming from the heart, typically the most common reason is atrial fibrillation. And when we image these patients, this is kind of an example of what we typically see. We can use different sequences. This is a DWI, which looks at diffusion of water, where we can see an area in the brain that has restricted diffusion. And that's kind of showing up here as this, bright area here in the aspect of the brain. Our goal, and again, the goal of emergency rooms when we send these patients in for a stroke, is to try to dislodge that blockage and restore blood flow. And in doing so, timing and specific patient presentation timing is very ideal. And you'll see this will be synonymous as we're talking about both brain stroke and eye stroke. Ideally, it's always thought 3.5 to 4 hours. That's when we want to try to intervene. So symptom onset until when we can try to get this intervention going. But that stroke window has expanded up to 6 hours. And so really, if we can get these patients seen and addressed within that 6-hour time period, they have the best chance of potential recovery. When we see stroke in terms of brain, the things that we typically think about are IVTPA. So basically, we're administering medication into the arteries to try to break up that blood clot. And then for larger blood clots, potentially a mechanical thrombectomy, which is considered a minimally invasive surgery where they're going to actually insert a catheter up into the groin and try to actually kind of suction that clot out in and of itself. Typically, after any type of ischemic stroke, patients will be put on some sort of blood thinner, in addition to aspirin and cholesterol medications, with the goal being really to minimize any future impacts from stroke. This is, different from hemorrhagic stroke. This is typically going to be that other 10%. Can happen from a couple different reasons. Hypertension, though, is the most common cause why hemorrhagic stroke happens. But it can also happen more so to, genetic predisposition in terms of patients who have aneurysms or AVMs that potentially rupture. And one important thing to kind of point out is some patients that have ischemic stroke can actually then convert to hemorrhagic stroke as well. So sometimes we can actually see both mechanisms happen here. When we get any sort of bleeding into the brain itself, we can get bleeding into the brain tissue with intracerebral hemorrhage. We can get bleeding into the subarachnoid space, which can be really concerning for things like Turson syndrome, where we know that blood can actually go down the optic nerve sheath, go into the eye itself, causing papilledema and potentially vitreous hemorrhage here as well. When this type of stroke happens, this is typically why, first line these patients, when they come into the emergency room with stroke-like symptoms, why we typically do get CT scans before we get MRIs. With CT scans, this is typically going to look better for blood and bone. Actually, some ischemic stroke can even be missed here, but really we need to rule out hemorrhage. If we think there's an ischemic stroke and we give these patients IV TPA and they have hemorrhagic stroke, it's just going to make them bleed more. And so we usually do CT again first line to try to make sure there's no evidence of hemorrhage before any sort of medicine is going to be administered. As we're kind of trying to treat these patients, typically goal is going to be to control blood pressure, especially if it's elevated, treat any brain swelling. Sometimes this is going to involve a craniotomy. Sometimes it's going to involve like an external drain. And then from us as eye care providers, we want to rule out papilledema in these patients because we have something physically taking up space in the brain. And then obviously, then ultimately, these patients typically do sometimes need surgery to try to evacuate that hemorrhage and potentially treat a blood vessel issue if it's there, in instances of aneurysm or AVM. So we can kind of look at this patient. This patient actually, when I moved to Jacksonville Beach, presented and saw me probably within the first month that I was there. And it was a 48-year-old female who was actually a surgical tech in upstairs in the clinic where our cataract surgeons were doing surgery. And, she got sent downstairs because, she was upstairs, she was dropping things, she was walking into walls, feeling clumsy, and kind of her other coworkers noticed that something was off. The symptoms had started about 2.5 hours ago, from when she presented to me. And on exam, her vision was 20/20 in the right eye, 20/40 in the left, so a little reduced. But she had this dense constricted visual field here, that was really concerning, especially with the other neurologic symptoms. And so we ended up sending her right to the ER, where again, they did a CT baseline and they noted this 3 centimeter mass that looked like an aneurysm in the internal carotid artery. They also noted some subarachnoid blood adjacent to the mass extending into the sylvian fissure. And, there's a large left, internal carotid artery aneurysm just distal to the left ophthalmic artery origin. So that kind of gives you an idea. It was very close to the optic nerve itself, if not compressing the left optic nerve, measuring by about 2 centimeters, and the neck of the aneurysm measuring 7. So really, really big. About 2 months later, we saw her. She still had this pretty dense right homonymous visual field defect. She did undergo cochlear embolization. She had a drain placed and 2 stents. Ultimately, her vision did suffer a little bit. That homonymous defect did maintain, and I've seen her actually, it's now been probably, 3 years since that point, and a little reduction in vision in the left eye with an APD, kind of confirming that there was a little compressive effect on the optic nerve as well. And we can even see that here on her OCT. So visual symptoms are important. So initially, when we think about stroke, and there for a long time, they only thought about FAST. So this was face drooping, arm weakness, speech difficulty. That means it's time to call 911. And then they introduced adding B into this acronym to include both balance and vision changes. But I can't tell you the amount of times I've had patients come in and be like, well, I had this change to my vision, but my face wasn't drooping, or I could move all my body parts. I didn't have any weakness, so I didn't think I was having a stroke. It was just something that was happening to my eyes. And I think it's important for patients to realize that you can have isolated symptoms. It just depends on what part of the brain is potentially being affected. And we know with occipital lobe primarily being visual, sometimes those symptoms are purely vision related. In addition to afferent in terms of field loss, also double vision is included in that. So that is something for our patients in general to be aware of that just primary vision can be a symptom in and of itself. Now, majority of strokes are preventable. About 80% of strokes are preventable if we're identifying those risk factors appropriately. So we know the big ones. These are the big risk factors for a lot of different things that happen from an ocular disease standpoint. High blood pressure, diabetes, high cholesterol, obesity, smoking, and heart disease. Again, atrial fibrillation being the most common reason. Now, there are some things, and this is going to be that 20% that aren't modifiable. Obviously, patients, as they increase in age, will naturally even see an increase in blood pressure sometimes in these patients. Patients who can be hypercoagulable, like in pregnancy or inflammatory disorders, and patients who have viral illnesses, patients with a familial history of, blood vessel, abnormalities or connective tissue disorders that make them more susceptible to aneurysm or AVMs. All of these things can sometimes be things that, you can't change that might naturally increase your risk for stroke. Now, transient ischemic attacks, patients oftentimes call these mini strokes, and I kind of hate that word. Even when we talk about some eye things, we'll kind of approach this again. Really, this should be a warning sign. If a patient's having anything that feels like stroke, but luckily it was transient, this really can potentially foreshadow a stroke that might come soon. And this is true in about 15% of patients. So that might not think that's a super high number, but it's still quite notable that 15% of patients after they have a TIA-like event might then move on to have a full-blown stroke. And about a third of patients can have a severe stroke within that first year. So that can really kind of show you up to a year point. They have some time to try to make to modify their risk factors. These happen due to temporary blockage of the blood vessel. So the blood vessel does get blocked, but not long enough that we see any functional or structural changes when we image these patients. Those deficits don't persist. I mean, even myself, when I was a resident, I can actually remember a patient coming in with a hematomatous visual field defect. And they came in really quickly. We did the visual field right away, probably 2 hours. We sent them to the ER. They had imaging. Nothing showed up on imaging. And we saw them back, I think, a couple days later, and their defect was completely gone. And so sometimes it can even be that quick where we see that happen. And again, this will kind of lead up to some ocular conditions that do some similar things. So again, blockage is shorter, symptoms, last longer than, things like ocular migraine, right? But they're still going to be short-lived, typically go away within those first 24 hours. So here's our first poll question. So what percentage of patients have a stroke after a TIA?
Okay, the polling question is open. And Joe, are there any questions?
There are no questions, but as the poll is going forward, Kelsey, the terminology is very, very interesting. I had a patient referred in to me for a consult last week, and they had been evaluated at the hospital, and it was determined that they had a retinal artery occlusion or a central retinal artery occlusion. And I think they even had ophthalmology consultation, but when I saw the patient was actually doing very well, and there was no evidence of an artery occlusion in the history. When he got into the history, I shouldn't say just, it was clearly a TIA. So a lot of people still don't understand what's really happening here, even in the ER.
I believe it. I think it also speaks to, again, the importance of at some point maybe having fundus cameras in the ER because oftentimes there's not, optometry or ophthalmology there to see these patients and the ER is kind of shooting blind when it comes to eye issues. They don't really have the tools to really get a good look in the back of the eye. And, if every ER had non-madriatic cameras and they could take pictures of the back of the eye, the patients could even come up with their pictures of this is what I looked like then, or again, we can use technology to try to see these pictures while the patients are there so that we can try to address the complaint quickly. Because again, the thought behind CRAO is, could we get these patients intervened within those 6 hours?
Yeah, I just had a patient. Actually, I was one of my patients. My wife saw because I was traveling. and she was texting me in between, when when I had cell service on, taxiing on the plane. And sent her to the ER. I mean, her fundus was perfect. I mean, it was that fresh of a central artery. It was that fresh of a branch artery occlusion. I mean, it was pristine. I mean, I saw the photographs. She got there. She had 12 minutes in the window of TPA,
That's
and
great.
her blood pressure was too elevated. They couldn't do it.
That's too bad.
All right, so we have, I'll display the results. We have 1% going with 5%. We got the winner being 81% at 15%. And then 50% just dropped down to 17 and 19 and no 100%. So your winner is 82% now, 15 or answer B.
That is correct. So about 15% of patients are going to have a stroke. And again, a third of those patients are going to have it within the first year. Okay, so let's shift a little bit and let's talk about blood flow to the brain. So how do we get here really? So really it all starts with the heart. And, we already mentioned a little bit things with atrial fibrillation, with that being a common cause of stroke. But really the heart's going to kind of be our origin for everything. And when we think about the anatomy, we have some important structures that arise, as we leave the heart. So we first have our ascending aorta, which is going to be here, and it arises from the left ventricle, where it's going to give rise to both the left and to the right coronary arteries that are actually going to supply the heart itself. We then move on to the aortic arch, and we're going to have the right brachiocephalic trunk, which is then going to give rise to both the right common carotid and the right subclavian artery. And then separate from that on the aortic arch, we're going to have our left common carotid artery and our left subclavian artery, which are going to be separate from each other. We then kind of have our descending aortic as it goes onto its abdominal aorta. Now, this is important in that differentiation between the brachiocephalic trunk because there is a little, it's an interesting vascular disorder called subclavian steal syndrome, which can sometimes give some ocular symptoms. So this typically happens due to a proximal occlusion of the subclavian artery, which then causes reversal of flow into the ipsilateral vertebral. So we go, subclavian up to the vertebral artery. So we can see that in this illustration here. Here's our vertebrals. And, typically our blood flow should be going to the brain. But what happens, and again, this is not where the brachiocephalic trunk is, it's on the other side. We can get this blockage here. And then we can get our vertebrals right here. And because of that blockage and the arm needing blood flow, it'll actually pull down the circulation from the vertebral arteries to go to the arm. And so again, we frequently see it on the left side. These patients can get these kind of intermittent symptoms of the posterior fossa, most classically. And it can happen both to, posterior cortex, but also to the cerebellum. And again, it's usually when the patient moves their arm. Actually, I remember when I was a resident, one of my attendings noted that they had a patient who had this, and every time they would bowl, they would have transient visual loss. So symptoms can be transient visual loss. It could be nystagmus. It can be double vision. Again, anything that's typically going along with that posterior circulation, which we'll talk about a little bit more here in a few slides. Often, if you're suspicious of this, if you check blood pressure in each arm, there's about a difference of about 20 millimeters of mercury, with usually the arm that's affected having a lower blood pressure. And the most common reason what we see with this is atherosclerosis. Now, again, when we think about the heart, the one thing that we really is notable is typically patients who have cardioembolic stroke. So stroke, again, originating from the heart. Oftentimes it's in multiple territories. So again, this is usually more ischemic because we're getting an embolus that's dislodging and moving elsewhere. And these patients can have stroke-like deposits in the anterior circulation and in the posterior circulation. It could happen on the right side and on the left side because, again, it's pumping through the heart and it's going in multiple different blood vessels as it's going to the brain. And so that's very specific. If we see a patient who comes in and they have strokes in multiple vascular territories, it's very likely that the heart is the origin of the stroke. When we think about the heart as the potential cause, I've probably already said it 5 times, atrial fibrillation is definitely the number one. Other things that we think about are patients who've had recent heart attacks. For our younger patients, patent foramen ovalis, this is a big one. And this is one that I always think about too in patients who have like atypical migraines. It's not uncommon for patients who are migraine sufferers to potentially have a PFO here as well. And so something to always think about in these patients who have frequent migraines. Again, younger patients, about 25% of the population can have this. But what happens is you get this abnormal connection. So it can cause an embolism that can form between, the right and the left side of the heart. We can see also aortic arch atheromas. This is another frequent reason why patients can get stroke, probably number 2 after atrial fibrillation, where we get these kind of large ulcerated plaques that can form actually in the heart, the aortic arch themselves. We can see it in prosthetic heart valves. That's why these patients are typically on anticoagulation. Usually, if they're on anticoagulation, that risk really decreases. And then infective endocarditis, not something that happens frequently, but when patients have it, about 1 in 5 patients who have it can potentially get complicated by stroke. So that is something to be aware of, especially if you work in any sort of hospital setting, that if a patient has bacterial endocarditis or they have bacteremia, so an infection of the blood, that they have a significantly increased risk of stroke. Something also to think in patients who are immunocompromised, they're again a greater risk of this happening. So when we think about our circulation systems, we think about our anterior circulation and our posterior circulation. That's kind of what I was talking about when we think about those multiple territory strokes that happen from the heart. So with our anterior circulation, that's going to start with our common carotids, and then it's going to branch into their 2 main arteries. You know that there are more because they go to the eye, but our 2 main ones are going to be our anterior cerebral artery and our middle cerebral artery. For our posterior circulation, that's going to be our vertebral arteries, which arise from our subclavian arteries. Those arteries are then going to come together at the base of the pons to form the basilar artery, and then branch to give rise to the posterior cerebral artery as its main artery. Now, this is kind of our just like general picture to think about those different circulations to the brain. From a vision standpoint, I'm going to tell you, we're really mostly relying on our middle cerebral artery and our posterior cerebral artery, our anterior just a touch, but our MCA and our PCA are definitely those big ones that we're going to think about just due to those distribution of those really important structures. So thinking about our anterior circulation, some important clinical correlates to kind of come back and think about one being carotid artery stenosis. So this is going to be blockage of the carotid artery, usually due to plaque, can increase our risk of stroke, but sometimes can cause those transient visual symptoms here as well. It has a prevalence about 5% of the general population. So, not terribly high, but definitely notable. We can do some diagnostic tests to try to determine these. Bruit is one of them, to be honest. I don't think I've ever heard of Bruit in clinical setting. Usually my go-to is going to be to order a carotid ultrasound or a duplex. We can also look into CTA, MRA, and then if we're really suspicious, potentially cerebral angiography here as well. When we're suspicious of these patients having this, when we do these tests to try to identify it, it then gets classified in either mild, which is less than 50% stenosis, moderate, which is 50 to 79%, and severe, which is going to be 80 to 99% blockage. If we see this happen, sometimes these patients are treated with an endarterectomy, where they try to clean out that blood vessel wall to get better blood flow. This is typically reserved for patients who are at least moderate, so about 50 to 99% blockage or stenosis with signs and symptoms. Ideally, we want to do this within 2 weeks of those symptom onset to try to minimize that stroke risk. In patients who have more than 70% stenosis without symptoms, typically intervention is also recommended. So again, we can think about 50 to almost 100%. They're going to do if there's symptoms involved. If there's 70% or more, they're going to do even if patients are symptomatic. Now, if it's 100% stenose, they're typically going to do nothing. At that point, especially if there's no symptoms, there's a higher risk of complications if they're actually going to intervene. Otherwise, typically collateral circulation is going to hopefully work in their favor. Sometimes stenting is done instead of an endarterectomy if patients have increased comorbidities, but really endarterectomies are going to be kind of the bread and butter. Another thing to think about in terms of the carotid arteries and our important clinical components from eye care provider standpoints is a carotid dissection. So here, typically, we're going to get damage to the carotid artery wall, and those layers are going to actually be mechanically separated, and you get almost like an aneurysm inside the artery wall. This can happen both extracranially or intracranially, anywhere along that carotid circulation. We do typically see this happen in younger patients, and it is a very common cause of stroke in younger patients in general. We can see it happen, potentially from any sort of trauma to the carotid artery. So car accidents, chiropractic manipulations, extended neck positions like in yoga or painting a ceiling for extended periods of time, really anything that causes trauma to that artery wall. We can also see an increased risk in patients who have certain connective tissue disorders, just like we see in aneurysm and AVM. Patients can be symptomatic when these happen, or they can potentially be asymptomatic as well, which can sometimes be more concerning because of that stroke risk. From an eye standpoint, typically we're looking at this right over here, which is our Horner syndrome. So patients typically present with headache or pain, facial pain, neck pain, and again, then ptosis and that pupil that's small on the same affected side. So when I teach Horner syndrome, I teach there's a small ptosis and a small pupil versus things like third nerve palsies where we get big ptosis, big pupil. So small pupil, small ptosis. We can do different drop tests like apreconidine to try to diagnose these to confirm that it is a Horner syndrome. But again, if we're highly suspicious of a dissection, so let's say the patient had trauma, they were in a car accident, I'm probably not even going to waste my time and do apreconidine. Also, if these are acute, sometimes our apreconidine testing isn't always going to be positive. And so that's another reason why I'm typically not going to do it if in these emergency situations for these types of patients. These patients, depending on the extent of the dissection, sometimes are just treated with antiplatelets or anticoagulation to prevent stroke and kind of look for that blood vessel to heal itself. Other times, sometimes the vessel has to be stented itself. These patients are typically on blood thinners for an extended period of time. Now, just like the carotids, the vertebral arteries can also have a dissection with the same types of risk factors. So trauma, extended neck positions, anything can cause damage, really to either of those blood vessels. Typically, the vertebral arteries are a little bit more protected just due to their anatomical locations. But I will tell you, I have seen dissections, both carotid and vertebral here as well. Majority of the time, these are going to be more intracranial, but we can see it really happen either way. But again, same thing, typically younger patients, trauma due to mechanical separation of that blood vessel wall. Symptoms here are a little bit different. No Horner syndrome because it's vertebrals, so it's going to be posterior circulation. Again, we can get pain and headache. But the most common things here we see are our lateral medullary syndromes, which we'll talk about here in a minute, and cerebellar infarctions. So we can get nystagmus, we can get ataxia. I said no Horners, but that was a lie because we can still get those descending autonomic fibers that could potentially be affected. We can see diplopia due to internuclear ophthalmoplegia and skew deviations here as well. These are a little bit more concerning. About 10% of these patients actually can die. However, if we diagnose these patients quickly, there's a good recovery for patients who do live. And just like carotids, our goal is to prevent stroke and keep these patients on anticoagulation. So we talked about our two circulations. We talked about our anterior circulation, our posterior circulation, and there's actually a point here where these two circulation systems connect besides the heart. So obviously they start in the heart, they divide, and they kind of come back together here at the circle of Willis. So here's an example of circle of Willis. We have our internal carotid arteries, we have our basilar artery, and then we have this kind of arterial ring that happens at the base of the brain around the level of the hypothalamus and the cerebral peduncles. So kind of near, I'd say like that midbrain thalamus junction. And we're going to connect these two systems. And the main artery here that's going to connect it is important from an eye care standpoint. So this is our posterior communicating artery. It's going to run really close, specifically medial to our third nerve. So we said again, it's at the base, of the brainstem near that midbrain, and that's where the third nerve is going to exit. And so we can actually see in this image here, this is midbrain. You can see those Mickey Mouse ears, and our third nerve is going to leave right here and travel medial to the structure of the posterior communicating artery. And we can get an aneurysm here potentially that can push on the medial aspect of the nerve and dilate the pupil and cause a third nerve palsy. Like I mentioned earlier, how I teach third nerve palsies, we have a big ptosis, big pupil. And if we have a pupil involved third nerve palsy, we know that this is potentially an aneurysm until proven otherwise. and specifically an aneurysm at that posterior communicating artery, which again is the connection between our anterior and our posterior circulation. It is also the most common site of aneurysms. So about 45, almost 50% of aneurysms happen here and have a high risk of rupture. So very important from an anatomical standpoint due to its close proximity to the third nerve. So here is our second poll question. Which blood vessel connects the anterior and posterior circulatory systems of the brain?
And that polling question is open.
Question came in, Kelsey. What is the
Yeah.
physiological cause of stroke associated with AFib?
For atrial fibrillation, so you can kind of think of it almost like you're getting these abnormal heartbeats. And sometimes those abnormal heartbeats can cause kind of little blockages within the heart to kind of dislodge and move into the circulation. That's my understanding of it. It's the irregularity of it.
Yeah, anything that prevents blood from flowing properly can allow it to clot.
Mhm.
All right, so looks like people were paying attention here. Nice trend in the direction of the correct answer. So I think I'll display it because we have 91%, 90%, 89% saying posterior communicating artery. We had 3, 7, and 2 for the other A, B, C answers. So 89% posterior communicating artery.
Perfect. So remember, it's important for two reasons, for third nerve palsies and connecting our two circulatory systems. So let's talk a little bit about our posterior circulation. So we know our posterior circulation, the primary thing we think about is going to the occipital lobe. But the other aspect towards it is it's going to also give some blood flow to the brainstem here as well. And the brainstem has some important kind of anatomical differences where the arteries that supply midline structures are going to be midline arteries. Our lateral arteries are going to supply lateral structures in the brainstem. And then we have these dorsolateral arteries, which will supply both the dorsolateral structures, but also our cerebellum. And those are going to be our inferior cerebellar arteries, both the anterior and the posterior. So when we think about stroke affecting these, important and anatomical standpoints from the back portion of the brain, our posterior circulation, occipital lobe stroke, of course, is going to be our number one thing that we think about. So we know when we get stroke to the occipital lobe, it's going to give us those kind of classic homonymous visual field defects. Typically, they're going to be very congruous and they can have macular sparing, where we see that central aspect of the visual field kind of not involved, which is great. And that happens due to that dual blood supply that we get from both the posterior circulation, but also from the anterior circulation here. Both the occipital lobe and the thalamus have that kind of unique property of that dual blood supply. Typically, vision is the only symptom, which is again, sometimes why patients don't think they're actually having a stroke when it happens. Oftentimes when they come in, they're going to complain of visual loss just in one eye, and typically it's going to be in the eye that has that temporal visual field. Now, homonymous defects, that's typically kind of our bread and butter, the most common thing that we see, but patients can have other symptoms. They can have visual hallucinations where they see kind of colorful objects in their vision, animals, shapes, faces, really anything. They can have prosopagnosia where they have difficulty recognizing faces. We see this more frequently in bilateral stroke more than right-sided stroke. And they can also have visual neglect where they're actually ignoring things to that side here as well and really are unaware that they're actually missing a portion of their peripheral vision. Those are definitely more complex symptoms. Patients or their caregivers might be more aware of that. But sometimes things like the visual hallucinations, sometimes the patients won't even admit to because they're scared of more of a psychiatric type of diagnosis. So here I have a case, a 73-year-old female who came in with kind of spots and images in her vision. Now she had a known stroke about 2 years prior. She had loss of her peripheral vision. And her MRI at that time noted, some right occipital lobe encephalomalacia from that old stroke. And we actually had some visual fields on her. But when she came in, she was noticing new floaters and spots, But sometimes she even said like it's not just a spot, it actually like looks like something that's not real. And so she reported episodes where it was a dog or it was faces, it was people. Other times it just looked like moving water. And she actually had one episode where she felt like the peripheral vision got significantly worse and then it kind of came back to normal. So these kind of, I'd say, visual hallucination like events. And we repeated her field, and her field, I mean, looked pretty similar. She had this pretty congruous, kind of unique appearance to this left homonymous hemianoptic defect. Definitely didn't look worse, but this was actually seizure activity. So she was having occipital lobe seizures from her old stroke that was causing these visual hallucinations. And as soon as she was put on Keppra, the symptoms went away. Her field didn't change, but she wasn't having those episodes of the visual hallucinations. So that's something a little bit unique of sometimes these symptoms that patients can get either as the stroke itself or post-stroke where they can get this abnormal seizure activity in the brain. Another thing to think about here when we think about posterior circulation is Wallenberg syndrome. So Wallenberg syndrome is kind of one of those classic syndromes we probably learned about in school. But it's important because these patients can have double vision and Horner syndrome. So this can happen due to damage to the lateral aspect of the medulla. So we get infarction of those dorsolateral arteries, the posterior inferior cerebellar artery. So oftentimes we can see this affect the medulla, sometimes the cerebellum as well. But these patients can have a Horner syndrome, they can have nystagmus, typically in gaze, and they can have an internuclear ophthalmoplegia or potentially a skew deviation as well. Now, we'll talk a little bit more about those brainstem manifestations of diplopia, but we're going to stop here for a brief second for our third polling question of what is the name of the condition that affects the lateral medulla and can cause a Horner syndrome, nystagmus, internuclear ophthalmoplegia, and a skew deviation. And again, this is important because sometimes when we get our patients' MRI reports or their discharge summaries, it'll say they have this specific syndrome, and we'll know then what to look out for.
Okay, the polling question is open. Joe, questions in the chat box.
Nope. No, we're good.
Polling question is open. Answers are rolling in. This is a reminder to everyone that what makes it synchronous. You're able to enter the polls in live. You're able to ask questions live. Well, I think everyone's paying attention again. We have, I'll display the answers. 78% lower this time than the 90%. We're going with Wallenberg syndrome. And then everything's about 7, 7, and 8 with A, B, and D.
All right. Awesome, right? Remember, Foster Kennedy gives you that swollen nerve and a pale nerve. Talitha Hunt's going to give you that kind of idiopathic inflammation in the cavernous sinus. And Weber syndrome is going to give you more of a brainstem, different type of brainstem stroke. But Wallenberg was what we were looking for specifically with the medulla. Now, I mentioned, briefly about our brainstem manifestations of diplopia, what we can get, because typically when patients come in with double vision, it's not something necessarily that we're going to say, oh, you need to go right to the ER for. But there are a couple different reasons why we might want to send them. And so really when we're looking at internuclear ophthalmoplegias, skew deviations, gaze palsies, and any sort of new central localized like nystagmus, then we potentially would, because we're really affecting our medial longitudinal fasciculus potentially, that's sending that kind of crosstalk information for the eyes to work together. And so we can think about that with horizontal gazes, like what happens with the gaze palsy. So we're trying to make the eyes go to the right or to the left. With internuclear ophthalmoplegia, we're trying to get that crosstalk between nucleus of 3 and nucleus of 6. 6 is our horizontal gaze center. It's going to try to send those signals to 3 to make the eyes move to the left or move to the right, but we get disruption in that. So 6 is still fine. It sends that abduction, but it tries to send a signal to 3, but it can't. So we get an adduction deficit, but 6 keeps sending it and gives a nystagmus. I'm going to show you that here in this video right here. To your left. And so you can see there's no adduction. This woman has a binocular INO. few beats of nystagmus as well. But also in skew deviations. And skew deviations, I remember everybody hated this learning it in school, but it's really this non-comitant hypertropia that's not a four. So with fours, we get that classic, Park's three-step where we get a hyper deviation that's worse in contralateral gaze and ipsilateral head tilt. With skews, it's just it's the opposite typically. So we have a hyper, it's usually worse in ipsilateral gaze. And then we have a deficiency with torsion, where the hyper eye is usually incyclotorted instead of excyclotorted, instead like a four. So again, if it doesn't fit a four and it's a hyper, we see that adduction deficit with abducting nystagmus. We see a gaze palsy. These patients, we do not do outpatient workups and we send them to the ER for at risk that they potentially have a brainstem stroke. Shifting now, so we talked about posterior circulation, thinking about the occipital lobe, thinking about brainstem. Now shifting towards our anterior circulation. So we have our anterior cerebral artery, again, less of something that we see to be affected. It's pretty rare to have a stroke of your anterior cerebral artery, but our middle cerebral artery is a different story. This is the most common blood vessel that gets implicated in stroke. It supplies a very large area of the brain. It has 4 segments that are divided into M1 through M4, but big area, I think big blood vessel, most likely to be infected from stroke. And some of those symptoms are vision related. So some are not. We can get contralateral loss of sensation, contralateral motor loss because we're above both the sensory and the motor decussation. We can get contralateral gaze palsies due to the frontal cortex. We can get contralateral homonymous visual field defects. We can also get visual neglect, like we mentioned in occipital stroke. We see this happen more frequently in right brain stroke. And we can get aphasia. So if it's left-sided stroke in the superior division, usually it's going to be Broca's aphasia, which gives these kind of short, limited sentences, versus Wernicke's aphasia, which is more that word salad where we get this kind of jumbled speech. Okay, so my last one, I guess so. So we are gonna change things up a little bit and go through some cases. Unless, are there any questions before I move to cases?
Nope, you're good.
All right. So we have a 58-year-old female who comes in with sudden visual loss in her left eye, and she was working at the time, and she just all of a sudden couldn't see one half of her computer screen. She said it had been already present for the last 6 hours. From a systemic standpoint, pretty pertinent. She does have a history of cancer, small cell lung carcinoma, which she was currently undergoing chemotherapy. She was an active patient in our clinic. She actually was scheduled to get a YAG for some PCO in her left eye, and she had Fuchs corneal dystrophy. So her exam, her vision was stable. This was kind of her normal level of vision at the time. She was 20/50 in the right eye, 20/70 in the left. No APD. Motility was full. Color was fine. Pressures were fine. Her anterior segment made sense with what we knew about her. She had some notable corneal luttata and some PCO in the left eye. Posterior segment was normal. So of course, things, really don't add up. Let's get a field. And she had this very dense, and it was on confrontation fields as well, but I didn't want to give it away, a left homonymous hemianopic visual field defect. So we sent her down to the ER. I didn't have her specific images, but this kind of matched it. So she had this new ischemic stroke here in the right occipital lobe. And so during her workup, it actually revealed that she actually actively had endocarditis. She had no idea. Now she was on chemotherapy, which probably put her at risk. But besides this sudden stroke she had, she was completely unaware of this infection that she had going on. So she was started on IV antibiotics. Unfortunately, her visual field did not get any better. But again, potentially this diagnosis, ended up saving her and getting her diagnosed with this, concerning condition and, temporarily halted her chemo. Next year, we have a 49-year-old female with left-sided visual loss, and she was actually found on the ground after vomiting. She was unable to move the left side of her body, so she was transported to the hospital. She had a CT, again, that's typically done first to look at blood, and demonstrated a dense subarachnoid hemorrhage, kind of originating in the right temporal lobe with some intracerebral hemorrhage as well. And they actually noted multiple ruptured right MCA aneurysms. She underwent choroidal embolizations. She had a right craniectomy because of basically how intense this was, with about 10 centimeter evacuation of a hematoma, and had an EVD placed. So when we saw her, she had been, had a couple of months of since this started, and she was really just having really poor vision here in her right eye. She was count fingers. She had a hard time even like ambulating to our chair. 20/30 in the left eye. No APD though, so extensive visual loss in one eye, but no APD, which is, pretty notable. Couldn't really do any tests well on the right eye because of the level of vision. Pressures were fine. Anterior segment was normal. We got a field on her and kind of just got this generalized loss in the right eye, not unexpected with that level of vision, but this temporal defect here in the left eye. So we can think a couple different things here. Could this be some sort of chiasmal syndrome? Like, could the blood have extended down a little bit more? And that's why we have, dense loss in one eye and temporal in the other. But then we looked in her eye and we saw this. We couldn't see anything, just like she couldn't see out. And so she actually ended up just having this dense, kind of old vitreous hemorrhage that was non-clearing. Because again, remember, she had intracerebral and subarachnoid hemorrhage. And so she actually had Terson syndrome. So she underwent a pars plana vitrectomy. Her vision improved to 20/25, and she did then have that homonymous visual field defect, but she had much more functional vision because she could see out of her other eye, and so she was able to ambulate much better and had a much better recovery. Now we have a 60-year-old man with distortion in his left eye with reading on the left side. So really, again, similar to all the other symptoms, symptomatic only for one eye, asymptomatic in the right. The blinking, squinting helps, no double vision. And at this point, like really nothing screams stroke about this, but his symptoms specifically started after he had an aneurysm rupture and was in the hospital. So we kind of go back, we get his history. About 4 months prior, he was in an emergency room for altered mental status, lethargy, slurred speech after he had a fall. And he had a CT head, which showed this kind of extensive subarachnoid hemorrhage. He had a CTA head and neck, which showed this really large saccular aneurysm at the left PCOM artery. Again, we know PCOM, this is important. It connects our anterior and posterior circulation. It can cause third nerve palsies. Ironically, he never had double vision. And so he had a coil embolization. He had a drain placed because of the hemorrhage. Later, though, they actually had to then do a pipeline flow diversion just because of how big this aneurysm was. So again, it comes in, he's only complaining of distortion in his left eye. Vision pretty normal. We looked at his motility because we thought, hey, you had a PCOM artery aneurysm, you should have a third nerve palsy. But really was pretty full. He just had a flick of an exophoric posture and was a little, myopic with astigmatism, nothing crazy, and a little bit of presbyopia. But again, he's symptomatic. So we get a field on him after we look at the rest of the back of the eye, and especially we see maybe some questionable pallor. And here's his field. So he had this little kind of non-congruous homonymous defect. Now, different than what I said earlier, typically when patients have homonymous defects, they complain of the temporal field. Ironically, he was complaining of his nasal defect here in his left eye. And, potentially, and I'll kind of explain it a little bit sooner, I think potentially it might have gotten the nerve here a little bit as well, which is why he noted it a little bit more. And again, we questioned some pallor and, nothing notable on the OCT, but potentially could have been, I didn't have ganglion cell at the time when we did this test. Otherwise, we would have seen if it was on ganglion cell analysis, might have been a little bit more notable. But he did have this right homonymous hemianopic defect, and we thought it was likely from a left optic tract lesion. We know the location of his aneurysm was PCOM. We know PCOM is near midbrain, and we know that our optic tract runs right kind of adjacent to those cerebral peduncles. And so it's right in that right area where that tract probably got affected. And so we thought if we got him some single vision glasses, brought things a little bit higher, potentially it would get out of that little defect that he had. And so we wanted to see him back in 3 months because potentially this could have improved on its own as well. But to our surprise, he came back a month later because he had to undergo another surgery due to that residual aneurysm. And when he woke up from the aneurysm, he noted that he had ptosis in a ghosted image. And so I'd say not so much to our surprise. Here's that third nerve palsy we were looking for. So he ended up having an iatrogenic, meaning from the surgery, third nerve palsy. So we can see he had a hyper that got worse as he looked up. It did not reverse when he looked down. It was partial. And he also had this big exo posture that increased when he looked away from the affected eye. And so, very classic third nerve palsy. So again, likely from the repair, we were hopeful it would get better. So we fit him temporarily with the Fresnel. We didn't repeat his field yet. It was too early. And so we had him come back. And fortunately, a month later, he was already starting to improve. Still a notable defect, but went from 30 exo to 18. So almost cut in half. And about 2 months later, his double vision had actually completely resolved. His ptosis had resolved. And so he was able to finally go back to work, was able to work with frequent breaks every 20 minutes, but overall was doing pretty good. And, at this point was really just kind of a flick of exophoria, which just a little hyper when he looked to the right. Finally, a year later, really resolved quite nicely, but his homonymous defect did stay there. Now, sometimes we do see, whether it's from hemorrhagic stroke or ischemic stroke, we can see visual field defects improve. Typically, it can be anywhere, I'd say, from, up to a year from the stroke, but those biggest changes typically happen within the first 3 to 6 months. But for him, unfortunately, his defect did remain, but he did compensate for it quite well. So just kind of showing that it really didn't change too much. All right, I believe our last case here, we have a 67-year-old man who presents one both post-stroke of the right PCA involving the right occipital lobe and temporal lobe. He notices that his vision is just darker, he's harder to see to the left, but was, most interesting about him is that he wasn't just complaining of the field loss, he was complaining of issues with his color perception. And again, the fact that his vision was just overall darker. That's what bothered him more than anything, is not the loss itself, but was the darkness and color in and of itself. Now, I'm keeping him short. About 3 months later, he did improve. So he really kind of, that whole inferior aspect did resolve. He really just had that superior defect that remained, but just that small improvement. So I say small, it did improve about 50%. But just that improvement in and of itself, really made him significantly more functionable. One, from a driving aspect, potentially. He did go through a driving simulation. But overall, that color deficiency that he was noticing was improved, and his vision was overall a lot brighter. He was much happier. And it's important, again, to just point out, it's not just field loss. There's a lot of higher order function that happens in the occipital lobe and surrounding structures that sometimes these patients can be symptomatic for here as well. All right, we're going to shift gear and now talk about blood flow to the eye. Any questions so far?
No, we're good.
All right, let's keep on moving. So we talked about our carotid artery and how it goes to those major branches of the anterior cerebral and our middle cerebral artery. However, we know that our ophthalmic artery is actually the first major branch of the internal carotid artery. It's then going to give, rise to the central retinal artery, which is going to supply the inner 2/3 of the retina, our posterior ciliary arteries, which are going to supply our choriocapillaris and our cilioretinal artery, and then our anterior ciliary arteries, which will supply our iris and our ciliary body. Now, I brought up, our TIAs, and we're going to talk about the TIA for the eye, or amaurosis fugax. So this causes that kind of fleeting or transient monocular blindness. Typically, these patients have this sudden episode of visual loss. They describe a shade or a curtain coming over their vision. Typically, it can be altitudinal, peripheral, or potentially central. But what makes this different than migraine is, one, it's typically unilateral, and two, there's no positive visual phenomenon. It's typically only darkness, grayness, or whiteout of the vision. There's no colorful lights or anything else that's going along with it. Typically quite brief, 10 minutes or less is typically what we expect. And usually these are painless. Now, patients who have this, just like, again, stroke and TIA, there is increased risk of stroke on that same side. And typically we want to look at both carotids and cardiac as the primary sources. Now, another big thing, and we'll talk about this more in detail here, especially from the vision standpoint, is in any patient over 50, the number one thing in addition to stroke is ruling out giant cell arteritis. So we're looking at STAT, CBC, ESR, CRP, or to be honest, I'm going to send these patients to the ER anyways. And while they're going there, I'm going to make sure that they're not just getting stroke workup, but they're also looking into giant cell arteritis as well. Now, artery occlusions. We already talked about this a little bit here, but we know with artery occlusions, we're going to get, occlusion of that central retinal artery, which again is the branch of the ophthalmic artery. This most frequently happens from emboli. And here we see that carotid artery disease is typically the most common embolic cause, followed by that aortic arch atheroma, which is those ulcerations in the aortic arch. We typically don't see the emboli. Oftentimes they're going to occlude, further back where the central retinal artery is going to pierce the optic nerve sheath. In branch retinal artery occlusions, though, we typically do see the blockage. Just like stroke, important risk factors. So high blood pressure, high cholesterol, smoking, diabetes, and atrial fibrillation, heart disorders, and valvular disorders as well. And oftentimes when these patients go to the ER after artery occlusions, a new vascular risk factor is frequently found. So here's our fourth poll question. What is the most common cause of artery occlusions in the eye? So both central and branch artery occlusions, what is the most common cause?
Getting that polling question open right now.
Not a question came in, but a statement came in. Lots of information. Will this lecture be on the website? And the answer is it will be on our YouTube. It will be on our YouTube channel.
And I believe they
That's
should
what-
have the handouts for the slides as well.
Yes. You can also download the course notes on the right hand, the icon on the right hand side.
It's ironic. I was, looking at my slides again for this lecture, and I thought, man, I haven't had a central retinal artery occlusion in a while. I shouldn't have said that, because then what happens? Last week, central retinal artery occlusion comes in.
Yeah.
Yep, it's the jinx, right?
You know,
All right.
interestingly, I had a patient, I saw him in follow-up from a central retinal artery occlusion, and he is one of two, maybe three, in 30 plus years where he actually recovered over several months.
Yeah, I'm hoping this man recovers. So he was 91, but he actually went to the ER. So he had the symptoms and he went an hour after symptoms to the ER. They didn't give him IVTPA, but he said he chewed 4 aspirins as soon as it started. And then they gave him, they gave him at least like, I think 2 Lovenox injections. So when I saw him, you could actually see like particles of the embolus breaking off. Um, he actually reported that his vision was a little bit better. It just started though, so who knows? But I'm cautiously optimistic that he might have a chance.
Yeah, my fellow, he went from 2,400 back down to 2020.
Yeah, it's
And
incredible.
over a course of about 2 months, his afferent pupillary defect disappeared.
Mhm.
I'm
And
gonna
that was spontaneous.
Yeah.
display the results here. Carotid artery disease was 74%. AFib was 16%. Autoimmune disorders was 0, and hypertension was 12.
I did hype atrial fibrillation up a lot, but here, carotid artery, #1 cause here. And we'll talk about that and why here in a few slides here. So when we think about emboli here, typically when we see them with artery occlusions, we can get calcific cholesterol or platelet fibrin. Platelet fibrin is the one you want. But calcific is going to be kind of these large yellow-white lesions. Again, this is when you see them. Cholesterol going to be a little bit smaller. But the platelet fibrin are unique in that they're usually kind of more dull, gray-white, but they're mobile. So they're more likely to kind of break apart as they kind of travel through the vasculature. And just like Joe was kind of talking about earlier, we see this happen more frequently in those transient CRAOs where patients can get some visual recovery. So this is kind of the unique thing we think about in the way I explain it to patients. So, when they studied CRAOs, they found about, again, 40% of patients with CRAOs had carotid artery stenosis of at least 70% when they presented. But what's most pronounced is that it's not about the amount of stenosis as much as the amount of plaque. because this plaque, as it breaks up, it's going through cerebral circulation before it gets to the eye. It's going through the internal carotids. It's branching off to the ophthalmic artery, and it's eventually getting to the eye. These blood vessels are tiny. So these emboli are microemboli. They're really, really small. And, potentially they could be breaking off and even going into aspects of the brain. And the patients are not even having symptoms because of the small size. And so really the amount of plaque is actually the most important aspect of the carotid artery disease that's causing these artery occlusions to occur. Now, we talked about emboli. It can happen from thrombus as well, not as frequently though. And we typically see it happen in kind of patients with hypercoagulable disorders, but also in patients with vasculitis, including giant cell arteritis. And that's the most common cause of a thrombotic event that's going to cause an artery occlusion, and usually more of an ophthalmic artery occlusion than a central retinal artery occlusion. Now, we can see this with other disorders that are autoimmune that can cause vasculitis as well, like lupus and sarcoid and granulomatosis with polyangiitis. But again, something else to think about with artery occlusions, that it's not just emboli potentially we need to look into, but potentially thrombotic events, which again are typically hypercoagulables or vasculitis as well. So these are considered rare. Just like I said, it's been a while since I had one, even though I had one just a couple days ago. But we do see it happen with increasing age, and we do know that our population and kind of age is increasing right now. These patients do present typically with sudden and painless visual loss, typically unilateral. Visual loss is variable, typically quite severe though, unless they have a ciliary retinal artery that's not affected. We do expect to have a large APD and a pretty decent visual field defect. That classic finding though that we see kind of early on in artery occlusions is retinal edema and swelling. So with central retinal artery occlusions, we're going to see this kind of diffuse area of interretinal edema with sparing of the macula, which is why it typically looks like that cherry red spot. This one in this picture is a little bit darker because this patient is African American, so it just depends on their layer, their pigment. In our branch retinal artery occlusions, we're only going to see it in that artery that's potentially affected. We'll see kind of box scarring of the blood vessels, where we can see them kind of break apart and come back together. We see arterial attenuation, and that typically persists even after these patients, I don't want to say resolve, but when we see the retinal edema going away, typically the one thing that does persist are those arterial attenuation. That can give you an idea of what potentially something happened. Probably more helpful with branch artery occlusions because you'll see it just in one specific distribution. Optic nerve typically looks normal unless the ophthalmic artery or the posterior ciliary arteries are occluded. Then we might have disc edema, or sometimes we can see, that embolus right at the layer of the disc. But again, more frequently, we don't see it. Now, just like with stroke, our goal is to really dislodge the offending agent in a timely manner. We know our stroke window is typically, 3.5 to 4 hours, extended to 6. But this has been studied, pretty specifically in the eye, and most things with vascular disease was done by Hayray. And what Hayray found was that there was no detectable retinal damage with central artery occlusions for 97 minutes or death. So complete recovery if that vasculature was restored after 97 minutes. But it was irreversible massive damage of over 240 minutes, aka 4 hours. And in between that time period, we got some improvement, but there was still a variable degree of damage. Now, what's interesting, and again speaks to that transient CRAO, is that where retinal circulation was restored to normal of more than 2 hours, but less than 4, it took a really long time for that recovery to happen. It did not happen right away. It happened many hours, sometimes days after that circulation was restored. So, it can take time to potentially get improvement, but I do usually caution my patients that that's very unlikely. So there are 4 distinct CRAOs, and I will say that's something I really didn't learn about until I was in my residency. So our classic one is our non-arteritic CRAOs. This is going to be the majority of them. They have those kind of classic findings that I just described, and we see it a little bit more frequently in men. Now, our transient CRAO, if you're going to have one, this is the one you want. About 15% of patients. When they come in acutely, it looks just like a classic non-arteritic CRAO. If you were to get, fluorescein angiography or potentially OCTA, though, you might see that there's some normal retinal circulation already kind of happening. This typically has the best visual prognosis, but it's not a common one to get. The next one is non-arteritic with ciliary retinal artery sparing, really kind of just a variety of our most common one. But we do happen to have that anatomical variant of having a ciliary retinal artery, which is a branch of the ophthalmic artery that's separate. And so we can still have some circulation in that area. And if your patient's lucky, that circulation might be serving the macula. And finally, our least common and our most visually devastating is our arteritic, which most frequently happens from giant cell arteritis. So these patients typically have that signs of artery occlusion, but they also might have optic disc swelling and choroidal ischemia as well. So really, really poor vision. This one is more common in women, which is classic for GCA just in general, and usually an older age. So again, just like brain tissue, our goal is to dislodge the embolus, try to improve vision, but unfortunately, there's really no good treatment options available. It differs from the natural history of visual improvement. And really the problem with that is the time of onset to treat these patients. These patients often don't get seen within that 4 to 6 hour window because usually they go to us as eye care providers first. They might not go right away. And then by the time that we do get them in and see them, we might already be beyond that window. So ideally, again, when that BFAST acronym I talked about in the beginning of the lecture, patients knowing of, hey, if I lose vision in an eye, I actually should go right to the ER and ideally maybe get IV TPA. That's kind of the hope. But again, the problem with studying that in terms of if it's efficacious is getting patients there in that timely manner to show if it even does anything. But that's the hope. So in general, if we see these patients, especially, if they're past that window, even if they're in the window, this is a stroke. It's a stroke to the eye. It's synonymous with stroke. So these patients do need to go to the ER for a full stroke workup because really this is defined as a stroke. So in 2013, and again, I feel like it was recent, but it really wasn't. 12 years ago, this definition was changed by the American Heart Association and the American Stroke Association that included in the definition of stroke both brain, spinal cord, or retinal cell death. And so again, it really is in and of itself definition of stroke. So if you have a patient, they don't go to the retina specialist, they don't go to the ophthalmologist, they go to the ER for proper workup because our goal is to prevent future events. So, some things that we found that kind of prove this is in patients with these acute, both central and branch retinal artery occlusions, or TIAs, if they have imaging, brain imaging, specifically MRI, that about a quarter of these patients actually have small little strokes or small little infarcts on the exact same side. But again, they're small. These are microemboli. And so patients might not be symptomatic, even though they are acute events. They also found that patients with acute CRAO were more likely to have a second stroke or heart attack within the first 30 days, with that peak onset being within the first week. And so that's why we really want to kind of get these patients to intervene in a quick manner. Now, our goal, once we evaluate them for acute stroke, is to determine, where it came from, just like with stroke, whether it's an embolus or it's a thrombus. Again, and you're going to see me reiterate this a few times, GCA needs to be ruled out in anybody over 50. If this gets ruled out, we want to look at our carotids. We want to look at our heart as our main cause. And some of our younger patients or with no other explainable cause, potentially looking at some hypercoagulable workups here as well. Now, usually, like we said, we're going to get pretty poor visual improvement in these patients, but really, if there's a chance of visual improvement, it depends on a few factors. One, how long that ischemic event happened. Ideally, we want about 97 minutes or less. Where the embolus was. So if we don't see it, it's not a bad thing. If it's pretty far back, then we might have some collateral circulation coming from the ophthalmic artery that might allow the nerve to recover a little bit better. And then the type of CRAO. Obviously, we all would want our patients to get transient CRAOs because they do have some chance of improvement. Now, any questions right now about CRAOs before I switch it up here a little bit?
Nope.
So let's talk a little bit here about ocular ischemic syndrome. This, I would even argue, is maybe more rare than our CRAOs, but it's pretty rare, but it is a vision-threatening condition that usually happens from very severe carotid artery occlusive disease. basically causing decreased blood flow to the eye and orbit. Patients more likely are symptomatic, but they can be asymptomatic as well. Lots of different symptoms can potentially present here. So sometimes patients can have visual loss. Pain is present about 50% of the time, slightly less. And it usually happens from either increased intraocular pressure or from direct, ischemia to the eye itself. And what's a little bit unique is that that pain can sometimes improve with laying down. So that's one important thing to try to ask patients when they're trying to localize these kind of non-specific pains. So a lot of different signs, and really, you can have a couple of these, you can have one of these, it really just depends. The one I'd say we probably all think about the most frequently is these mid-peripheral hemorrhages. That's pretty, I'd say, specific towards ocular ischemic syndrome, especially if it's happening only in one eye. But even things like conjunctival injection, corneal edema, spontaneous hyphema, iritis, neovascular glaucoma, asymmetric cataracts, all of these can sometimes come into play. Any sort of asymmetric retinopathy is always going to be a red flag here for me. Potentially even ischemic optic neuropathies is something to kind of look into. And then again, don't forget about the orbit. So we talked about those branches of the ophthalmic artery, and some of them go to the orbit itself. So these patients can have orbital pain, they can have ophthalmoplegia, they can have ptosis, even hypotony potentially. And so again, really not specific, but anything that's affecting blood flow to the anterior segment, posterior segment, or the orbit in and of itself. So we have our fifth poll question here. So ocular ischemic syndrome involves which portion of the eye?
The polling question is open.
Kelsey, I think it's important to emphasize, as we all do, to our colleagues, that when you see a central retinal artery occlusion, it is nothing that the retinal specialist wants to see or needs to see.
No.
Everybody thinks about retina
Mm-hmm.
because retina is great. Retina will see anybody. You got a patient to see neuro-ophthalmology, that's 6 months.
Yeah.
Person to see neurology, that's 6 months. Person retina says, just come on down. Yeah, sure, send them. No worries.
Yeah. I've already
They'll,
got
they'll see
30 people
they'll
waiting
see
for this
anybody.
one. Yeah.
But yeah, you need to bypass the retinal specialist and get them to the hospital because they might be in that TPA.
Mhm.
And for everybody to also understand that the fresh artery occlusions look awful normal.
They do. Sometimes that retinal edema can be pretty subtle too.
And the chances of neo with a central retinal artery occlusion is minimal. It can happen, but dead is dead. And that's why it's more likely to happen with a branch or a vein occlusion at a central because it's still alive and screaming for help. So helps the hospital.
I'll still
All right.
see them I'll see them at 1 month intervals, until I hit that 90 days. But again, they're ER first always.
Yep. And audience paying attention. We have I'll display 81% going with all above, with posterior segment going 16%.
Perfect. And that's, again, probably what we think about the most frequently. Again, those kind of asymmetric retinopathy cases. But I do think it's important. And the pain can be non-specific. I mean, how many patients come in your clinic and are just like, my eye hurts, and it's sinus related, right? But kind of thinking about that and looking at all the things from a different perspective, or looking at their health, if there's anything else that might be a little red flag of, could it be carotid artery disease potentially causing an early ocular ischemic syndrome? So we said atherosclerosis, most common reason, typically more than 90% of stenosis is what we're getting. So it's really bad. And again, we find ocular ischemic syndrome as the initial manifestation in carotid artery disease in about 70% of patients. That's pretty high. We want to, as eye care providers, once it gets diagnosed, we need to treat those sequelae that could potentially happen. So we might need to treat eye pressure. Sometimes these patients might need intravitreal injections if there's any signs of neovascularization. But ultimately, we need that surgical treatment to the carotid artery in and of itself to get it opened up to get blood flow back to the eye. So
Kelsey, my experience has been, while you can have a neovascular situation with elevated pressure,
Hmm.
they're almost always, I found, hypotenuse because the ciliary
Yes.
body is not getting
Hmm.
fed. And I see too many people, I guess you say, overcall or overdiagnose OIS. And my first question is, what's the pressure? And
Yeah.
if the pressure isn't single digits or sky high, I tell them, so you're barking up the wrong tree.
No, I agree with that. The handful that I have seen, pressure is typically always lower and notably lower on the affected side.
And what I think a lot of people don't understand is the overall mortality of patients like this. These are very sick people.
Hmm.
The last I heard was the 5-year mortality on OIS was actually worse than melanoma,
No,
real
that's crazy.
melanoma.
Yeah, I believe it. All right, so we have some cases here. So we have a 48-year-old African American female who comes in with a 6-hour history of reduced vision here in the left eye upon awakening. So, we're talking about those windows. We're kind of right at her window right here, 6 hours. It had been stable since the onset, and she kind of just describes this big purple smudge in her vision. A little bit of discomfort, some pain around that left eye sinus area as well, but otherwise nothing significant to note. Now, she had been a patient at our clinic for the last 18 years. Historically, vision was 2020. She really just had one episode where she came in with a corneal ulcer, but vision recovered quite well. She did have type 2 diabetes for the last 5 years and high blood pressure, high cholesterol. She did have medications for all of those and was taking them, but for some reason, the last 2 weeks, she decided, I'm not going to take these anymore. And so had been recently off all medications. Now, we did check her blood pressure in office. It was not terrible, all things considering, at the time. It was 120 over 84, but her pulse was a little high at 96 beats per minute. She also was a smoker. She smoked about 3/4 of a pack per day for the last 20 years. And then her family history was a little bit important to us because her father did suffer from a ruptured brain aneurysm, and her mother passed away 9 days following on complications after childbirth of really unknown cause. So some things to kind of keep in our back pocket. So vision in the right eye was fine, but she did have reduced vision in the left eye. Count fingers at 3 feet with a big old APD. Decreased peripheral vision, most notably centrally in the left eye here as well. Incidentally, we noticed she was a little proptotic, so got some Hertels, pretty symmetric though between the two eyes. Motility was full. Slit some xanthelasma in the presence of that high cholesterol. She had a little corneal scar from that old ulcer. No iris neo, anterior chamber was deep and quiet, just a little bit of early cataracts. Pressure was symmetric. Here was her field. Now, I'm not going to lie to you. I actually was, pretty convinced at this point that this patient was going to have optic neuritis, just some sort of like atypical optic neuritis because of how bad the vision was, the APD, unilateral, one eye. That was kind of my bet as I was about to look into this patient's eye. Um, but then we kind of get the OCT and we're like, all right, she had a little bit of moderate cupping here in this left eye, a little bit of thickening. Again, could still be optic neuritis. But we also see on the ganglion cell that it was a little bit thicker actually on this left eye than the right eye. So a little unusual. And this you probably recognize as the picture I showed you earlier. She actually had a central retinal artery occlusion. So right eye, nothing too notable. But left eye, again, this kind of subtle retinal edema. You're actually seeing the choroidal circulation underneath, really narrowing of these arterioles here as well with some box scarring. So she did have acute CRAO, so we sent her to the hospital. She was kind of at that 6-hour mark, probably by the time we dilated her and did all the testing, because that's not what we expected. Probably at that 7-hour mark now. She did have multiple vascular risk factors that needed to be addressed. We were going to plan to see her back in a month after her hospital visit. So while she was in the hospital, she was hospitalized for 4 days. She had a CT, CTA of the head, no MRI, unfortunately. She had a transthoracic echocardiogram, which was normal. Again, looking at that cardiac source. CTA of head and neck, so looking at the carotids. Her blood work, she did have some elevated cholesterol, which we kind of knew that, she was not compliant with her meds. And so she was discharged on atorvastatin. She was started on aspirin and was going to follow up with us and follow up with the neurologist. But she ended up following up a week earlier because she was worried about going to her contacts. But she did note that her vision was a little bit better, which was surprising. And she also stopped smoking, although her blood pressure was still quite high. And her vision was 2250. Still had an APD, but it was a little better. No iris neo. but her field was, notably better here with just this kind of central scotoma and, inferior arcuate. We can still see that retinal edema and arterial attenuation, but definitely some improvement that was happening, which was kind of surprising. We still got her glasses prescription with Polycar, more of a balanced lens. We did give her a hypercoagulable workup just because of her family history and, not an alarming stroke workup, I'd say by any means, besides the things we already knew. And we're going to have her come back as scheduled, at that month visit. But again, her vision was even better. And I'll show you here in a second. They did change her aspirin, changed her blood pressure medications to control it better. And then she did end up getting an MRI ordered by her new neurologist. She unfortunately did restart smoking and hadn't done our blood work yet, but her blood pressure was better. And her exam, kind of similar to the patient Joe was mentioning, did improve. Her vision improved to 20/20 with refraction. Still had an APD, but notably smaller. We can see her field again improved with just this little central scotoma. But as expected, we can see some ganglion cell layer loss. But overall, pretty remarkable recovery in vision. And again, not what we typically see, but this was a transient CREO. Now, as I mentioned, we can still see this arterial attenuation. And that's again something that can sometimes will always linger after one of these, artery occlusion events. So we were pretty pleased that she, had this improvement, which is not expected. Now, she finally did get the blood work. Her ANA was quite high, and she did have elevated anticardiolipin antibodies. So we did think she probably had like a hypercoagulable condition that increased her risk of having a thrombotic event. Now I have another case, kind of an interesting guy here. He was a 58-year-old man with transient dimming of his vision when he looked up. Very specific, only when he looked up. He had noted it for the last 2 weeks. No symptoms in the left eye, no eye pain. He did have high blood pressure and high cholesterol and was presbyopic. Exam was pretty normal up until the dilation. So vision was 20/20, pupils were fine. There was no APD, motility was full. Little asymmetry here in the eye pressure, 10 in the right eye, 14 in the left. And then he did have these kind of scattered peripheral hemorrhages just in that right eye with, again, that lower pressure. So we were concerned for ocular ischemic syndrome. So we ordered a carotid ultrasound. It came back normal. We were still suspicious. So we got a CTA head and neck, still normal. And I will say this patient was, again, a little different than what you said, Joe. He was pretty otherwise healthy. But he ended up getting an angiography because again, his symptoms just kept persisting and and he actually had more than 90% occlusion of the right ICA that was not visible on the carotid ultrasound or the CTA, which was kind of terrifying to me. And I will say always something that lingers in the back of my head now when I order these tests of how potentially things, might be missed with these more non-invasive imaging technologies. But again, ended up ultimately then getting carotid endarterectomy and symptoms completely resolved. His peripheral hemorrhages completely resolved. His eye pressures became symmetric. But again, something to always think about if sometimes, non-invasive is good because it's non-invasive, but if you're suspicious, keep digging. Now we're going to touch on this a little bit. Any questions?
Oh, let me just check. Okay, so question comes in, if I have a patient with BRAL
Mhm.
and medical history of AFib and recent device procedure to regulate a heart, is that still an emergent visit to the ER?
Yes. So difference between Hollenhorst plaque and BRAO. So if it's an acute BRAO, so you're seeing edema, patients having symptoms, visual loss, then yes, this still, even though they have a vascular risk factor, I would still send them to the ER because we can't blame the AFib. It's possible that it's coming from the AFib in and of itself, but we don't know that for certain. Or if they did recently have a procedure, could something be maybe wrong with it? So I would definitely send them to the ER. Now, Hollenhorst plaques are different. These are usually found incidentally. There's no edema associated with them. And we actually don't find that these have increased stroke per se. So they don't have to go to the ER, but an acute BRAO does. Any other questions?
No, interesting. We talk about the asymptomatic Hollenhorst plaque. I was actually lecturing with a friend of mine who's an internist.
Mm-hmm.
And he said that if you send the patient like that to him and you ask for carotid studies, he said 100% of the time I'm going to do the carotid studies because you as an optometrist asked me to do it.
Yeah.
And a lot of times we don't like what we find. If we find something, we may become compelled to do something. He said, it would be better if you saw that, tell me what you found, and just ask me to do a general atherosclerotic evaluation.
Hmm.
And that way it frees me up to do what I think is best. He said, because every internal medicine colleague of mine has at least one patient in a wheelchair as a result of a carotid endarterectomy.
That's fair. Yeah, I think it's a good point. And for a long time, I would think Hollenhorst plaques did have to go to the ER. And again, when I was at Emory, I will say their team was big on artery occlusions and stroke. But again, Hollenhorst don't, the mechanism's not the same. And again, like we're still getting circulation behind them. They're usually coming from somewhere else. These patients need to be worked up, but not acutely by any means.
Mhm.
All right, so we're going to touch a little bit on ischemic optic neuropathies. We don't have too much time, and you'll still have the slides, but it's something I do just want to bring up here a little bit, just because it is a part of what we think about when we think about kind of blood flow to the eye. So let's talk a little bit about them. So, typically these are, going to be these vascular optic nerve disorders with sudden severe visual loss. And we do typically see them in patients who are older, both with and without vascular risk factors, depending on if it's non-arteritic or arteritic. So non-arteritic, these are typically going to be acute, painless visual loss, and it happens frequently between males and females, more frequently Caucasian, usually a little bit younger compared to arteritics. And vision can be anything, but I think what's most pronounced is that it's very rare for them to be worse than hand motion. They can be, but not typically. Oftentimes their central acuity is not bad. It's more the field loss than anything else, with these inferior altitudinal arcuate defects being the most common. The defects really kind of follow the retinal nerve fiber layer. Now, the nerve can be diffusely swollen, it could be segmentally swollen. It typically looks a little hot though, it looks a little hyperemic. We can see some hemorrhages, we can see these kind of dilated capillaries at the disc, and then we often see that the other nerve is small and has a small cup, which we often term the disc at risk, which we can kind of see in this illustration here. But again, a bunch of different things that we can see. Sometimes we see them after the event and we just have some segmental disc pallor. Sometimes we can have diffuse swelling with hemorrhages and cotton wool spots. It just really depends on the presentation in and of itself. Now, the biggest thing here is this vascular workup. Just like what we talked about with stroke and artery occlusions, this typically happens with microvascular compromise. So high blood pressure, diabetes, high cholesterol, smoking, sleep apnea, decreased blood pressure, so hypotension, nocturnal hypotension. We can see in hypercoagulable conditions, anemia, optic disc drusen, and after ocular and non-ocular surgery. For non-ocular surgery, typically when the patients are laying face down. My big five are high blood pressure, diabetes, high cholesterol, anemia, and sleep apnea. Those are probably my big ones that I see the most frequent associations with. And then I go through the medications. So, questionable association with erectile dysfunction medications, questionable, I'd say, with amiodarone, because we think it's more of like a toxic type of optic neuropathy, more frequently bilateral. And then now there's all this thought about our GLP-1 agonists, but those are going to be the three medicines I always ask about. So this has been kind of in the headlines here. We talked at our academy meeting here a few weeks ago, but all of this kind of came out last summer about potentially GLP-1 agonists causing blindness. And majority of this came from Mass Eye and Ear and kind of looking at these patients who were on GLP-1s, and they looked at them basically their kind of cases that they had in their clinical setting of patients who were taking them for diabetes versus patients taking them for weight loss. And they did find a very strong association that patients who were on these medications had a significantly increased risk. And specifically, it was those patients who were taking it where weight loss were found to be at an even higher risk than the patients who were diabetic. Now, again, this was a tertiary referral center, so they were getting tons of patients with ischemic optic neuropathies. Since then, I will say there have been a couple other studies that came out that don't have as strong of an association. But again, it's hard to know because they're seeing the bulk of these patients. So I do think it's something to be aware of. Whether or not it's causing it is hard to say with certain, but I do think it's something that should raise a red flag in terms of when we're looking at what potentially could be risk factors for these patients. Now, this is a diagnosis of exclusion, so we do need to rule out giant cell arteritis. It is the most important thing to rule out in these patients because the prognosis is completely different. And the presentation can be somewhat similar. So usually stat ESR, CRP platelets, we're looking to see if they're high. And sometimes if we're really suspicious, we'll even consider a temporal artery biopsy. We sometimes do need to rule out, compressive lesion or atypical optic neuritis. So I will often image these patients, particularly if they're nervous swollen for more than 4 weeks. We don't really know why it happens, but we do know it's just due to this transient disruption in the circulation at the disc, at the optic nerve itself, in a small confined space, which causes somewhat of like an anterior compartment-like syndrome. Now, unfortunately, there's no known proven beneficial treatment. Vision typically stabilizes within 2 to 3 months. Some people get a little improvement as the swelling goes away. Oftentimes, patients tell me it's almost like the cloud is lifting a little bit, it's a little bit brighter, but the visual field defects typically don't improve as much. Now, there is a chance that it can happen in the same eye, about 5%, so not frequent, but about 15% of a chance that it can happen in the fellow eye within 5 years. So that's pretty notable, and usually something I caution my patients on by, again, wanting to minimize those vascular risk factors. Now, different arteritic ischemic optic neuropathies, typically more painful visual loss, most likely from giant cell arteritis, females more than males. Again, more frequently Caucasian patients over 50, but typically I see this in more older patients. Vision loss is typically profound. So I said non-arteritic, unusual to be hand motion or worse. Arteritic, more likely to be hand motion or worse. So much more visual acuity. Might have associated symptoms like headache, pain in the jaw or fatigue in the jaw when they're chewing, and tenderness to the scalp. With giant cell arteritis, we know this is going to cause inflammation in those medium to large blood vessels. Can happen in the ophthalmic artery or posterior ciliary arteries. That's what's going to cause visual loss. But it can also happen in our vertebral arteries, so we can get stroke. And it can happen in our temporal artery, which is why we biopsy there. Now, this is a medical emergency, and so we need to send these patients to the ER just like stroke. There is an association with polymyalgia rheumatica. So about 50% of patients with GCA can have PMR, and about 20% of patients with PMR can have giant cell arteritis. So if you have a patient who comes in with PMR, you might want to let them know about those GCA symptoms because it can be something to look out for. Now, the visual features of GCA can be temporal or permanent. Our goal is to catch them when they're temporary. So transient visual loss, transient double vision, that's when we want to try to catch them versus permanent, where we're going to get those ischemic optic neuropathies or potentially an ophthalmic artery occlusion, which can look like our central retinal artery occlusion. So here, our optic nerve can be swollen, just like in non-arteritic. It's typically going to be more of that pallid swelling, though, so a little bit more of that pale association, more cotton wool spots. I often find the disc edema isn't as pronounced as with non-arteritic ischemic optic neuropathies, and that's probably because if they're kind of pale, the fibers are already dead to a certain degree. But again, we're looking for that high level of ischemia. So here we can see cotton wool spots, again, that pallid disc edema here as well. So here, and again, I'm just going to finish up this section and then we'll stop. Suspicion's high, just like with stroke, we're going to send them right to the ER. We're looking for those elevated inflammatory markers. So ESR, CRP, potentially platelets because they're hypercoagulable. And our temporal artery biopsy is really going to be our gold standard in diagnosing this. But what makes this unique is that it is a clinical diagnosis. If we are really suspicious, we are going to treat it before we get that official diagnosis, versus normally we try to get the diagnosis before we treat. If there is visual loss, whether it's transient or permanent, we do IV steroids, whereas if there's no visual loss, these patients can typically be put on oral steroids. Without steroids, there's a really, really high risk of relapse in these patients. These patients are on steroids for years with a very, very low, slow taper. So we should expect them on steroids for 1 to 2 years. Now, Actemra came out in 2017, kind of changed the game here, where it can get patients off steroids faster if they're on Actemra with prednisone. So they found that this lowered the chance of relapses, so less relapses, and was very well tolerated. And we know there's tons of side effects with steroids. So if we can get these patients off steroids, really just a better outcome for them, altogether. So was better at treating relapses and again got them off steroids faster. Usually poor prognosis, these patients don't regain vision, which is why we want to catch them when they're transient. And there is a risk of the fellow eye much higher if they're untreated, which is why when that steroid is tapered, we watch them very closely in terms of their symptoms and their inflammatory markers. All right, I'm going to give us a stop here.
You actually have a few more minutes if you like.
Oh, okay. I'll talk quickly about amyloidosis though, because it's kind of interesting. So there is a GCA mimicker and it's happened in my clinic, so I like to bring it up. So amyloidosis can really mimic GCA. It is a systemic or kind of local disorder that can cause these deposition of fibrils throughout basically the organs, and that does include the blood and circulation here as well. It is a type of plasma cell dyscrasia, so it actually can happen with multiple myeloma. And it can happen from the eye a couple different ways. So we can get these kind of conjunctival lesions. We can get this periorbital purpura, kind of looks almost like a black eye around the eye. We can even get these deposits in the conj and in the retina, orbit, and even the cornea. Amyloid itself, that protein can deposit in the temporal artery, which can mimic GCA and even cause ischemic optic neuropathies. A little different, more common in men than women, but similar age, similar can have elevated ESR and CRP, and similar symptoms. So they can present with pain, in the temporal artery, visual loss potentially, transient or permanent. So if these patients get a temporal artery biopsy, it even shows giant cells like we see in giant cell arteritis. However, what makes it unique is that it has what's called Congo red stain, and that's very specific for amyloidosis itself. So this is the patient that I had who again was kind of giving us everything GCA like. Now he had an ischemic optic neuropathy, he had pallor, kind of this like subtle visual field defect, nothing notable, but pretty decent APD actually. He had this temporal headache on the affected side, had an extensive workup, everything came back negative, and actually he ended up getting a carpal tunnel surgery, and they noted some weird kind of scarring, and they biopsied it at the time, and he ended up getting diagnosed with amyloidosis from that carpal tunnel surgery. And unfortunately, now he's struggling because he has cardiac amyloidosis, which is, can be the most concerning from a life standpoint. And again, can increase the risk of stroke, increase the risk of our ischemic optic neuropathies here as well. So something to kind of think about in addition to giant cell arteritis, or think about in these patients potentially with ischemic optic neuropathy here as well. Time to do a couple cases or?
You've got about 4 minutes.
Okay. So I do like this one. So let's do this case here. So we have a 71-year-old man with double vision, started about 2 to 3 weeks ago. Seems like true double vision because it goes away when he covers either eye. His vision was also having other symptoms where he was noticing his vision kind of going out like a white screen, lasting for 10 to 15 minutes. Happened 3 weeks ago, and maybe it's only happened 2 to 3 times total. But again, was having these transient episodes of monocular visual loss. He also had some headache, eye pain behind the right eye. Eye history, not really anything remarkable, just presbyopic. Did have high blood pressure, did have high cholesterol, was taking amlodipine and allopurinol and lovastatin for all that. Now, what's notable is his daughter called me during the exam, was just like, he is not normal. He is not himself. This is not who he is. He's usually very active, but he's been very sedentary since these symptoms have started. So something is wrong. So on exam, his vision was a little reduced. He did pinhole to 20/40 and 20/30. No APD, confrontations were full. Eye pressure was symmetric, but he did have a right abduction deficit. Now, he had some notable cataracts that were probably accounting for his level of vision. And his rest of his dilated exam, for what we're looking for, was pretty unremarkable. Really, he just had this, I'd say isolated right abduction deficit with an increasing ESO posture as he looked to the right. OCT, MAC OCT, besides that little bit of drusen, was otherwise really nothing too notable. But we need to remember he was having efferent and afferent together. He was having a right abduction deficit and episodes of transient visual loss, also headache, also eye pain, and this kind of generalized malaise. So we were worried about something systemic. So we kind of just ordered kind of some basic blood work, including what we do for GCA, CBC, ESR, CRP. I was going to image him, so I also wanted to check his kidney function. He was going to go right today to get it done through his primary. He did have these visually significant cataracts. We're going to look at them later. So his blood work came back. His ESR was 41, which was high, but I'd say not like crazy high for his age. Usually for men, it's their age divided by 2 as our kind of high end of normal. But his CRP was through the roof. It was 160. Platelets were also super high, 586, almost double what they should be. So he's very hypercoagulable. So we called him, we sent him right to the ER. When he got there, his MRI did show these 2 small acute strokes, which he was asymptomatic for. He ended up getting a temporal artery biopsy, which was positive for GCA, and started on IV steroids because he had transient visual loss, and then discharged on oral steroids, and eventually put on Actemra as well. He did follow up about 3 months later. He was taking Actemra and oral prednisone, but a pretty low dose of prednisone for only being 3 months post GCA diagnosis, which again was because of the Actemra. His double vision was resolved. His abduction deficit was resolved. He did have 1 episode of visual dimming that lasted 2 seconds a few weeks ago, but nothing since. And his inflammatory markers were normal. Vision was a little better. Still obviously those cataracts, but his motility was now completely full. His ESO defect was resolving. And so, overall everything looked pretty good. Briefly, I'll just mention this other case of this 49-year-old woman, so kind of young, we're thinking ischemic optic neuropathy standpoint. Blurry vision, right eye 2-3 weeks. Really nothing else of note. Her systemic history was normal. So just anxiety, migraines, but no history of anything from a vascular risk factor, not smoker. Vision was pretty bad, 2400. She did have an APD. Eye pressures were equal. And she had this kind of classic inferior arcuate defect. And we can see on her OCT, she has this kind of diffuse disc swelling. Left nerve, it's hard to call it a disc at risk. I wouldn't say that with any certainty by any means. So here we have this woman with sudden visual loss. To be honest, more concerning for an atypical optic neuritis because her vascular risk factors were normal. So I did send her to the ER for imaging, thinking this might be more optic neuritis. But her hospital course was pretty unremarkable. Now, due to the concern that it could have been optic neuritis, that maybe they missed it on the scan, they did start her on IV steroids. And she thought maybe her vision got a little bit better, but nothing significant. She did at that point tell us she was taking Wegovy prior to this happening, but did stop it shortly before the event. Now here, her disc swelling's coming down. Her field actually looked a little worse. I don't think that was real, to be honest with you. Left eye still looks normal. Again, wouldn't necessarily say this is a disc at risk, but we thought maybe it was an NION. It was right when all the thing was coming out about the GLP-1s and this association. But we did want to kind of do a thorough workup. She had no diabetes, high blood pressure, high cholesterol, but we did want her to get a sleep study to rule out sleep apnea. And because we thought we were unusual, I did want her to get a second opinion. Now, she saw a neuro-ophthalmologist. They put her on ginkgo biloba to try to do some sort of neuroprotection, but really nothing else of note. Now, unfortunately, then her left eye became affected. Now, to the same degree, she was 20/40 in that eye, but she did have this secocentral scotoma and now some subtle disc edema in the left eye here as well. So unfortunately, she was that 15% that went bilateral. She did complete the sleep study, was diagnosed with moderate sleep apnea. She did to see low vision, she saw occupational therapy. They tried to again put her on a little prednisone to see if it did anything. It didn't. But again, one of those more unusual presentations where it did go bilateral and maybe some GLP-1 with some sleep apnea. Hard to say with any degree of certainty. All right. So that's all I have for you guys today. Any questions?
No, you have gone through well. There are no questions from the audience. I'm sure you're going to be getting your virtual round of applause in just a few moments, but I thought it was fantastic. Kelsey, thank you so much for doing this.
Of course, happy to
I
help.
loved it when I heard this live at our Disney meeting, and I knew that we wanted to bring this back and give people from across the country who didn't go to Disney a chance to hear this. I thought this was terrific.
Thank you. Appreciate it.
So up on the screen right now, you'll see the little red dot by survey. It's right here on your screen. You can start survey, then you won't have to wait till 10 o'clock that post event email. Please do that survey. It is required e-brokers and the ARBOs and the regulatory boards that are out there. And we have to turn this in. This is part of what Vanessa does and what we do to keep compliant. So please do that survey and get feedback. With that, Joe, are there any other questions for Kelsey?
There are none.
All right, Kelsey. Well, just like Joe said, heard it at Disney and heard it again here. It was fantastic both times. Great review, very thorough. Thanks for doing this. The grand rounds in vascular disease, this virtual course, the education now ended.
All right. You guys have a good night.
Thank you.
Good night, Matt.